Performing sterile dressing change.
Gather my supplies for my dressing change. I'm going to need a red bag for a dressing change, a blue pad, tape, my normal saline, my basin to lip.
Gather all of your supplies before you go to the patient's room.
Good morning, Mr. Jones. Okay, well, I brought my supplies in. Let me wash my hands.
Perform hand hygiene prior to beginning any procedure.
And I'm going to get on some clean gloves to protect myself. If I do anything that you don't like or if something is uncomfortable, you just let me know. Get my bed in position. Okay, let me check and see how everything looks.
Raise the bed to a comfortable working height for you.
The gown underneath you. All right.
Expose wound area without overexposing your patient.
Put on a blue pad.
You want your red bag secured to the tabletop and positioned so that the opening is where you can drop any soiled items into the red bag without going below the tabletop.
Fingers on the hair, the way the hair grows, like away from the middle of their body, and then I'm not going to really show the dressing to him.
Lift the dressing away from the client's face.
Drain out. I'm assessing for coca, color, odor, consistency, and amount. I'm assessing the wound site.
After assessing color, odor, consistency, and amount, you want to assess the incision for the 3 E's: erythema, edema, and exudate. Edema refers to swelling, erythema, redness, and exudate would relate to any drainage.
Glove to glove, and then I go underneath and pull off this glove skin to skin, and then I just drop it in the receptacle. I need to cleanse my hands. Okay. I'm going to set up my sterile field now. And tear the tape so I'll have everything ready.
Prior to performing any procedure, you would want to make sure that you sanitize this tabletop properly.
I'm going to tear one smaller piece for my date, time, and initials. Nurse Rhymes, well, I forgot my sterile gloves. I wear 7.5. Setting up my sterile field. Thank you. If at any time a 4x4 crosses the blue line, and if I'm in doubt, I'm going to throw it out. But if it crosses the blue line, it's considered not sterile.
The 4x4 should not move outside the lines of the gauze wrapper.
And notice I'm not crossing my sterile field with my arms. I'm setting everything away from me, but towards where it's close to the patient. I need to wet some sponges. I'm checking the label. It's normal saline and it's within date. Top down. If I was going to set the top down, I would turn the top upwards, but I'm just going to hold it face down. And lipping with the label in my palm, and the one closest to the patient, I'm gonna wet it first. My supplies I'm gonna put back here. I didn't turn quite my whole back on the sterile field. I kept in my peripheral vision. I'm right-handed. And grab the inner cuff. My thumb's going to be towards the ceiling because the thumb is at the top. And I'm going to work the glove on all the way and pull the cuff all the way down, because once I let go, I'm not going to adjust the cuff anymore. The second glove I'm picking up, my fingers are going into the outside part of the cuff, thumb up, and have my hitchhiker thumb up to the ceiling so I won't contaminate that thumb. Once you get your thumb going into the sterile glove, it usually everything should follow. And I let go of the cuff. Sometimes you might have to adjust your fingers. And now I'm going to do like a balloon technique so I can have several surfaces to be able to cleanse the wound area. I'm going to do the incision line first because that's the more clean area. The drain is the more dirty, contaminated area. So I'm going to write 3 strokes. 1 towards the head, 2, and another surface, 3. Always cleansing towards the drain. I'm going to dry the same way. But first I'm going to finish all the cleansing. Now I'm going to cleanse the drain site. I have to squeeze it out a little. It's pretty wet. The drain site you want to cleanse from 12 o'clock to 6 o'clock. And so on this incision line, you consider where the incision's going towards the drain is 12 o'clock. So I'm cleansing 12, and I'm going to do the proximal or towards the head first, and then cleanse the distal side. 12 to 6, the proximal side. And if you have to, you can take one finger and contaminate, and then I'm going to rotate and do 12 to 6 on the distal side. And you dry the same way. Incision line, down the middle, proximal, distal. We'll cleanse the drain again the same way, keeping that contaminated finger out. 12 o'clock where the incision line goes into the drain, 12 to 6, rotate, get another side, 12 to 6. I'm going to address the wound. First I'm going to cover up the incision line because that's the cleanest. You want to go on and get that covered. Incision line. And then I also want to pad underneath the Penrose drain because that's where it's going to be leaking and where you want it to be draining. Sometimes you have to keep one finger on your patient because my dressing's starting to slide and I don't want to contaminate. I'm going to completely cover, make it an occlusive dressing. I want the drain covered also so the tape won't pull it out the next nurse that needs to change the dressing. To be occlusive dressing, you want at least like 1/2 inch to 1/4 of an inch around the 4x4 taped and smoothed down on the patient's skin.
An occlusive dressing is one in which all surfaces of the gauze are covered.
Okay. My gloves are contaminated, so I'm going to remove.
Hand hygiene is always performed after removing gloves and prior to putting on gloves.
Got contaminated, but I removed without contaminating myself. I'm gonna date, time, and my initials. This I'm gonna put towards the midline because if drainage gets on it, you can't see it. Okay. You okay, Mr. Jones? And now cleaning up, I would want to put on some gloves. And these are just clean gloves. Check on your patient. I'm gonna remove the blue pad. Side rail.
Place all contaminated items in the red bag and remove from the patient's room and dispose of according to your agency's policy and procedure. Remember to perform hand hygiene again after removing gloves.
Hey, you call us if you need it. And I'll take this down the hall and wash my hands again. Now we're gonna demonstrate.
We will now review some
several
special
different wound
considerations in
areas
wound care.
and what you need to take in consideration anatomically and positioning before you do actual wound care. There's 2 different incisions, both Penrose drains. This one on this side, the incision's going from top to bottom. So on this type incision, you would cleanse the incision area first, then the wound where the drain is coming out. But this incision, the 12 o'clock is easier to think about, or where the 12 o'clock is, because it's towards the head of the patient. And the 12 o'clock on this patient is where the incision line meets the drain. So drain each time, one swipe, and then you
On
would
this
cleanse the
incision, you would
midline
clean the incision itself
that
from
side,
top to bottom,
and
and then you would clean the
outer
medial
the
side and then the lateral side.
and then dispose. That was cleansing, and then drying you would do the exact same way, but I'm gonna finish cleansing the drain right now. I'm gonna do the 4 corners with the wet sponge. The 12 o'clock, as I mentioned, is here, and this you would take in consideration. You would cleanse the midline first and then the outer side, the lateral, and you might have to contaminate one finger. I'm starting at 12 o'clock, going around the drain, rotate, 12 to 6, incision. This is the one you have to think about. You would want to cleanse, of course, the incision line first, and then cleanse the drain area. So, bottom, so gravity, you have to think about where the gravity goes. With this being a sideways incision, and you think about midline to out, this time gravity, you would take into consideration, it takes priority. So cleanse at the 4 corners, incision line, straight down the incision line towards the drain, and then you think about where gravity is. So you would cleanse the proximal side first towards the head, one swipe there, and then the side where the gravity would be going more distal there. A real patient, I would probably be on the other side to be more comfortable, especially doing this one. But you're gonna do 12 to 6. Now usually you think midline, but this time gravity is gonna be going this way for drainage, so you would wanna do the outer side first and then the midline part of the drain. I'm still going from 12 to 6 because 12 o'clock is right where the incision goes into the drain. So I'm doing 12 o'clock to 6, and that's on the top of the head and where gravity's not draining. And now you do the side where 12 to 6 where gravity, and it's probably, you could see probably drainage on a real patient. That was cleansing, and then you would dry the exact same way, and then dressing it, I would dress both incision lines, and then pat the drain and do an occlusive dressing.